Good evening. My name is Rick Christie. I'm executive editor of the Palm Beach Post, and I want to welcome you all tonight to our community forum called Fixing the Florida Shuffle, Next Steps. The idea for this community forum came from investigative work that was done by the Post regarding addiction treatment centers in Palm Beach County that we published back in September. We had the idea, the reaction we got from the community was so strong that we got the idea that people would actually want to come and talk about this and actually talk about possible solutions. So we scrambled and managed to get folks here tonight, and we hope that you really enjoy the discussion, the questions and answers, the questions from our moderator, and the answers from our panelists. And I want to say that I appreciate also our sponsors tonight, the Hanley Foundation and Palm Beach State College. And to that end, I'd like to invite up Barbara Cipriano, the provost of Palm Beach State College, to welcome you guys.
Thank you, Rick. I'm so excited to have all of you here. My name is Barbara Cipriano, and I'm the provost of this campus. How many of you know what a provost is? Raise your hand. Not many. All right, so think of me kind of as a principal. So I kind of run this campus. Thank you so much for joining us. We have a little construction going on campus, as you can see. So it was a little tough getting here, but thank you for being here. Some of you may not know, but we are probably the face of this community. We have 5 campuses across this large county where maybe it will take you 20 minutes to find a campus. And we're very excited. You know, what we do, our mission here is we are open access. We inspire hope, we advance skills, and we ultimately transform lives. That is our mission. But one of the other things we do is we gather people together to have these critical conversations of things that affect us in this community. So I'm very grateful to have you here. I hope that we have more of these conversations as this goes on, because this is where we should be doing a lot of our talking and finding our solutions. So with that, I want to shout out to our Director of Student Wellbeing, Robin Russo in the back, our staff, our students and faculty that are watching this live stream. So thank you to our sponsor, to our partner, Palm Beach Post, and have a great evening and a great dialogue. Thank you so much.
All right, thank you, Bar. So let me go ahead and get this thing started. I want to introduce Antigone Barton, a Post investigative reporter who also produced reported and wrote the Florida Shuffle along with our investigations editor, Holly Baltz. So, Antigone, I'm just going to turn it over to you.
Thank you, Rick. What we're talking about tonight is largely because Florida is known as a recovery destination, but it's also one of the few states in the nation that has assigned oversight of addiction treatment to an agency with no medical expertise. At the same time, epidemics of opioid drug use, heroin, now fentanyl, as well as changes to federal law that opened opportunities to treat young patients far from home, brought investment by unqualified and often corrupt operators into South Florida's drug treatment industry, adding to the numbers of people caught in the cycle we call the Florida Shuffle. Geez, I wonder what I was going to say next. Our first responders continue to run from one overdose to another, and we still confront a toll of preventable deaths in spite of strong efforts from our community, from the state attorney's office task force, from the healthcare district. So tonight we're going to discuss how we as a community can better address the Florida Shuffle. On our panel, we have Amanda Davidson. Amanda has experienced the Florida Shuffle firsthand. Her boyfriend, who also came here for treatment, disappeared and died from a drug overdose. He wasn't found for 4 months. Dr. Robert Moran is board certified in psychiatry, addiction medicine, and preventive medicine. Dr. Belma Andrick is the Chief Medical Officer of the Palm Beach County Healthcare District, and Palm Beach County Chief Assistant State Attorney Alan Johnson leads the office's Addiction Recovery Task Force. So we'll start with Al. When the State Attorney's Office started building the task force in 2016, can you describe what you saw firsthand that informed efforts to improve oversight of addiction treatment and recovery housing?
Well, in 2016, this was a mess. I had no knowledge of the space. I did consult with some people with knowledge. Mark Fontaine from what was FATA, which is now the Florida Behavioral Health Network, and various others in the industry, FAR, just to find out what was going on. And then the more we looked into it, the more corrupt the system was, and tragic. The results of the wholesale brokering of individuals in the private side. Optum did a study in 2015, and they found that 75% of patients in Florida on the private side, not the public, were from out of state. And the more we looked into it, and how many people here have been through some sort of a program and are from out of state? Okay, we have several people here. You couldn't go. They closed down in Delray Beach. We have Mark Wood here from Delray, who's the code enforcement guru from Delray. Delray Beach was the ground zero of Florida, which was the epicenter, and it was unbelievable. You couldn't throw a stone without hitting a sober home in Delray Beach. Most of them were run. People just rented a house and rented out rooms, and they were convicted felons, and it was all a brokering situation where the whole key was not recovery, but it was relapse, because relapse pays. We'll talk about that more with the failed acute treatment philosophy of the insurance companies for a long-term brain disorder.
So what did life in those places look like when you went out to?
I remember in 2017, Dave and I and Justin Chapman, who was our main prosecutor for the task force, went out on a fire rescue ride-along, and we went to Watershed, which is no longer. I've never seen a more depressing place. First of all, there was this guy at a gate, and there was a barbed wire fence around what was effectively 3 4-story apartment complex buildings like you would see in Century Village. And we slowly rode along with the fire rescue folks, and there were all these mostly male young adults that were standing outside drinking Red Bull and smoking cigarettes. And we'd stop and say, "What's your name? Where are you from?" "Oh, I'm from North Carolina. I'm from New Hampshire. I'm from Ohio." And everybody looked forlorn. It was not a very pleasant place to live, let alone be in treatment, so, in a compound surrounded by barbed wire. So that was, if I say that it was not only tragic, but it was outrageous. The way that people were treated when they came to Florida, they marketed to Florida, and it was all about the kickbacks back then. It was all about the kickbacks.
What you're describing, it sounds like just warehousing people, just giving them a place to be so you could collect the money.
That was what I noticed. And then we went further along on the ride along. Delray Beach has its own fire department. They were getting multiple calls every night, sometimes repeat people who would overdose in the afternoon, and then at night they would overdose again, go back to the hospital. I know Palm Beach County Fire Rescue, which is 50% of the county, had about 2,600 transports for suspected overdose in 2017. They're down to below 1,000 now.
Okay, let me ask, With that description of what you were seeing, people biding their time, being exploited, being used for their insurance money, I'm going to move to Dr. Moran, and I know you feel strongly about this. Why do you feel addiction should be treated by medical experts? How do we know that addiction is an illness rather than a social problem?
Antigone, how many hours do I have?
Yeah, just the usual 5. No, he can do this for 5 hours, but you've got about 2 minutes.
She knows me. 35 years ago, my answer would have been different. That was when I was in medical school. And we were taught in medical school that those individuals, in quotation marks, who chose to use substances repeatedly, despite having experienced negative consequences by their use, were making a choice. They were making a choice to destroy their lives. And they could just as easily make a choice to stop. You remember the slogan from Nancy Reagan, just say no. Well, 35 years later, we have a tremendous amount of medical research that continues to expand exponentially. There is no doubt that addiction is a brain disease today, and we've known it for over 20 years. And this is agreed upon by multiple organizations in the field: the American Society of Addiction Medicine, the American Academy of Addiction Psychiatry, the American Psychiatric Association, the National Institute on Drug Abuse, the Substance Abuse and Mental Health Services Administration, and the World Health Organization. Let me just take a minute to describe what the disease is. You know, we all have what's called natural or endogenous opioid systems in our brain. You've heard of endorphins. There are also enkephalins and others that the endorphins stimulate a protein receptor that sits on the membrane of a nerve cell we call neurons. And it's the mu-opioid receptor. There are risk factors for the development of addiction. Some are genetic, and the list of genes that increase the risk of developing addiction continues to increase over time as more research is done. In addition to the genetics, there's also the role of the early environment, whether the individual has suffered from some type of abuse and or neglect. These factors set the brain on a stage of development such that when that individual becomes exposed to an opioid for the very first time, maybe having been prescribed appropriately by a doctor or a dentist, discovers that he likes it too much. That's an indication of a variation of that mu-opioid receptor. That person has the genes that makes him more susceptible to developing addiction. I tell my medical students, by the way, that before they can prescribe any opioid pain medicine appropriately, that they must inform the patient who's never had one before that if you like this too much with that first dose, that's a medical emergency, and you must call me immediately. It doesn't mean that we'll deprive you of the pain medicine, but we're going to get someone else to control it for you. Well, with repeated use, the brain cannot tolerate the overstimulation of that mu-opioid receptor, and so it begins to attempt to compensate. The compensation occurs in those neurons which make up circuitry that are responsible for very specific brain functions. These brain functions include the following: judgment, which is in psychiatry defined as the capacity to predict the likely consequences of one's choice. If I do this, then this is likely to happen. Other executive function, which essentially is the capacity to think, to carry through a sequence of steps in order to accomplish a task. Impulse control, which is the capacity to think before acting. Mood regulation, anxiety tolerance, the motivation reward system, learning, and memory. We now know a lot about the neurocircuitry which is responsible for each of these functions. These become dysfunctional, and we see the expression of that dysfunction. It is the changed brain.
Can
That
you
is the
see the
disease of
evidence
addiction.
of that physically?
We can. If we do PET scans or functional MRIs, we can see the changes that are both structural and functional. That's the disease itself. It's not
Okay.
the behaviors that are the disease. The behaviors are an expression of the changed brain.
So it is complicated. And Let me ask, Dr. Andrick, when the health district began to look at getting involved because of the rising number of overdoses, and you began to look at what the scenario was that was allowing people to come here and yet fail to be treated, one of the things you did was looked into the medical direction of treatment facilities here. What did you find?
So healthcare district runs and operates federally qualified health centers. So we know very well what to do with any other physical health illnesses and how to connect them to appropriate care. Like Al said, we were kind of all new in this overwhelming crisis that our community was facing. So although there are other providers in the community who were traditionally providing substance use disorder, they were overwhelmed as well. So actually, Palm Beach Post reporter came in one of our board meetings and said, what do you do for substance use disorder? And that was kind of game changer, as Al said, in 2016 and 17, that we realized we have to have all hands on deck and really kind of dedicate some of our primary care resources to treat substance use disorder out of that house of medicine approach as medical doctor's office. And back in a time, it was very limited resources for especially underinsured and uninsured patients to have access to medication-assisted treatment, particularly Suboxone, that was becoming really standard of care and really recommended with all those agencies that Dr. Moran mentioned. So we started providing medication-assisted treatment out of our primary care wing. Substance use disorder is mental health illness. As such, has to be treated by psychiatrists, and not any psychiatrist. It has to be addiction psychiatrist. So the first thing we did, we hired addiction psychiatrists, we hired addiction-trained therapists, but as soon as we add all those resources, we were overwhelmed with the volumes. So we were constantly looking, what is a community, and in essence, public health intervention we can do that really address the enormous need in a community. And
when you reached out to see what kind of medical direction some of these facilities were receiving, what kind of physicians were serving as a medical director?
Since I was new and I'm coming on a medicine, we are very geeks in medicine. Dr. Moran will confirm that. We look for, I took a list of 105 providers that was listed on website, and I called every single one. In office, we actually split between 5 of us, and everybody had task to call and ask who is their medical director. We were looking for best practices. We were looking to peers to learn from each other. And of 105, we were able to identify only 10 names as the medical directors. And of those 10 names, majority were interventional radiologists, retired OBGYNs. We didn't find one single psychiatrist as a medical director of those 10 listed back in a time.
Okay, thank you. Now, Amanda, you came here for help. You came here in the hopes of finding meaningful, lasting, sustainable recovery. How did you figure out where to go? How did you pick a facility or treatment? And then once you were here and were in and out of treatment, how did you pick facilities after that?
Yeah, I think when I was researching places to go, and research is a strong word with my mental capabilities at the time, and I had been down here like 2009 for treatment. So I really leaned on the people that I had met at that time to help me find a treatment center. This would be end of 2021. What they recommended to me was a very nice facility. Their website was, drone footage of like an idyllic palm tree ridden like pool. There wasn't a pool, it was a different, but chef, it sounded great. It sounds exactly where you would want to detox, which, we don't have time to discuss like what that feels like from fentanyl, but it's horrible. It's uncomfortable. You're very vulnerable in that position. You want to be in a comfortable place with people who are, to be honest, kind to you. So that's where I went. I had a job that afforded me really good insurance to get into a place like that. The care that I received there, I'll say, was good in terms of comfort level and facilities and cleanliness, and I had an actual licensed therapist, I believe. And, we had groups that were scheduled. We actually went to the groups. We, had facilitators. So in that sense, compared to what I experienced after that, it was leaps and bounds above what I discovered, but it also wasn't effective. it was peddling this, abstinence only 12-step philosophy, which has been successful for a lot of people, but it wasn't really what I expected to find in a treatment center that my insurance was paying for. I could have found that in any church basement in the country. So when I left that facility and did end up relapsing, I didn't have that good insurance policy anymore. I had a state policy that I had gotten through the marketplace, and I realized pretty quickly that my options were quite a bit more limited. From there, I went to detoxes where we were just packed in there like sardines, sharing rooms that are designed for 2 people with like 4 other people, groups that had no facilitator, but you had to sign something because lest your insurance called and asked, you were in a group and they were going to pay for it.
And when you got out of the detox center, you spent the most time in, how did you pick the next place? Because you were now ready to be at least an outpatient. How did you pick the place you went to then?
Yeah, I didn't. They did for me. There's maybe not the kickbacks that there used to be, but there's certainly good faith agreements with detox and the next level of treatments. The place that I ended up going to, I couldn't look at a website. They didn't have one. I couldn't talk to anyone who worked there because my case manager said, why would you want to talk to the next person you're going to see? And I didn't. I thought that was an odd question. But yeah, it was chosen for me. It's pre-selected. You lose agency when you enter some of these places. You have no control over your treatment. It's not individualized. It's all predetermined based on agreements among these corrupt, frankly, actors in this industry.
Thank you. Yeah, Al, the task force had an overwhelming job because there's no state regulation of sober homes, and you instituted and you promoted legislation that would make it necessary that places reach a certain level of quality or standard of performance, and also increase vigilance on treatment facilities. As a result, a lot of bad operators did leave. Our number of treatment facilities went down here. They went up in other places. And so you've made a difference. The task force has made a difference. You start every meeting now, when you guys meet monthly or however often, with the numbers. You review the numbers. What are the numbers telling us?
They're awful numbers. 1 death is a tragedy, and then 500 deaths is a statistic. And it's, when we say it's gotten better, it's still horrendous. But let me give you a couple of statistics. Number one, the task force in the first 5.5 years, we filed charges on 121 cases. We've gotten 112 or maybe 114 convictions to date. There were convicted felons running treatment facilities. One was formally convicted by the feds for the George Brothers pill mill prosecution. Now, one of the things that does instruct us is to see how we're doing and to see how we're doing with the rest of the state. Because know this, Florida has always been a low regulation state. Let's face it. That's you're in here, it's a low regulation state. This area, we have been able to convince the legislature and the governors over the last 8 years to slowly increase the oversight. And one of the ways is we're actually doing better. And I just happened to bring a yellow piece of paper because I can't remember these numbers. So at the task force meetings, I'm reading off a piece of paper. But just to give you an example, in 2017, we had 647 human beings who died from opioid overdose. Okay, and that's before fentanyl took hold. Okay, in the state there were 4,279. So that was 15% of all the deaths in the state. Go to 2021, the last time we have state numbers. And by the way, everybody call or write or email to the Florida Department of Law Enforcement a medical examiner commission. Ask them where the report for 2022 is. It always comes out the end of November. Hasn't come out yet. It's almost the end of January. But anyway, for 2021, the last time we have state numbers, okay, we had 519, which was a 14% decrease from 20 when COVID hit in our county. The rest of the state went up 4%. We went down 14 in 21. And there was 6,366 overdose deaths in the state of Florida. So we're 8% now from 15. Awful numbers. One other thing is we have a medical examiner who's very cooperative in Palm Beach County. And we get those numbers, we email them, they get back to us in a day. In 2022, we have our numbers. We don't know what the state numbers are. I feel that they must be going up. Otherwise, the numbers would probably have been released. But what do I know? But we were down to 421 overdose deaths, which again is horrendous. But it's a 19% decrease over the 14% decrease we had the year before. So we're doing something right, whether it's chasing out all the scoundrels who are opening up in Broward or Hillsborough or Orlando or Duval County or West Virginia, or we have innovative programs that we've been able to bring the silos together. So we have the healthcare district with their remarkable program, the Addiction Stabilization Unit, that's being replicated all over the state of Florida. And with the cooperation now of the Southeast Florida Behavioral Health Network. So we really are rallying and getting together so that we see improvement. You know, telling a moth not to fly into a flame, you know what I'm saying, Dr. Moran? You can't do that. This is a long-term brain disease. And so it may not catch on the first time, may not catch on the second. Certainly we'd be better served with a long-term continuum of care instead of this acute nonsense of 5 weeks and you're out. You break your leg, you have physical therapy for 4 or 5 weeks, and they tell you, okay, you can go home and do the exercises on your own. You can't do that with a brain disease that lasts for years, that the brain physical changes that need to be addressed, and it's the long haul. I think we're moving in that direction with what we're doing in Palm Beach County. We got headwinds, but we're moving.
So basically, first tackling the corruption, chasing them out of town, and then getting people to work together, break down silos, and work towards goals that are based on evidence. Sounds like it is making a difference. I want to ask you, Dr. Moran, is there an understanding of a minimum established standard of care that should be followed in addiction treatment, which we have regulatory oversight over? Is there a minimum standard of care that should be, I don't know if I should say enforced, but that if a place is licensed to provide treatment, that is provided?
Absolutely, Antigone. There are national published guidelines that are based upon the research that I referred to earlier, published by the institutions I mentioned earlier as well. And in medicine, we use the term evidence-based practice. What that means is that we want to take what's in the latest research and integrate it into our practice. I tell our students that there is not one single medical illness that we treat today the way I was taught to treat it 35 years ago in medical school. And this is as a result of ongoing research. It's an evolution that I hope will never stop. But we have what's called an integrated medical model for the treatment of opioid addiction that has a tremendous amount of evidence to support its use. And it has 3 major components. One is, how we say in psychiatry, pharmacotherapy, which is a fancy word for medicine. And we have 3 effective medicines to treat opioid use disorder. I mentioned that opioid receptor earlier. The one medicine, naltrexone, blocks that receptor such that if the individual ingests some type of illicit opioid, they won't get any effect from it. It doesn't do a great job at decreasing craving, though. And so in my experience, it's most useful for a mild opioid use disorder. The next medicine is methadone, and that's been around for decades. And that is a medicine that is very effective at decreasing craving. All of the pain medicines, heroin, fentanyl, all opioids, fully stimulate that mu-opioid receptor, methadone included. Now, studies have shown that people who are on methadone are able to get jobs, they have decreased craving, they're less likely to get into legal problems, less likely to show up in the emergency department because of overdoses. So it has its benefits. But the downside is that you can only get it at federally licensed programs, so you have to attend every single day to get that daily dose, which is extremely inconvenient for people with an opioid use disorder trying to get jobs. The third medicine, and it's looking as if it's probably more effective than the other two, is buprenorphine. And Dr. Andrick mentioned it earlier that the brand name is Suboxone. And it is unique in a very special way in that of all the opioids that we have, it is called a partial agonist. It only partially stimulates that mu-opioid receptor. Now, when that receptor is fully stimulated by all the other opioids, it shuts down our natural endogenous opioid system. Shuts it down. So then when people present in opioid withdrawal because they've stopped using, that natural system may not turn right on. And so the lack of opioid activity is what creates the withdrawal syndrome. Buprenorphine partially stimulates it, which allows the natural system to gradually turn on, which enables the individual to come off the medicine in some cases, although more and more research is showing that most people with an opioid addiction, and by addiction we mean the severe form of opioid use disorder, will probably need to stay on buprenorphine inevitably.
Okay.
So that's the one component. There are two others. The second is evidence-based psychotherapy. And they include cognitive behavioral psychotherapy, dialectic behavior therapy, motivation enhancement therapy, mindfulness-based therapy, and family therapy. And these have lots of studies supporting their use in treating addiction. Finally, the third component is vocational/social services. Getting a job is therapeutic. And many of the patients who suffer from opioid addiction have never really had a long-lasting job because of the illness. In addition, there's exciting research supporting the integration of the 12-step program, Narcotics Anonymous, Alcoholics Anonymous, Cocaine Anonymous, into the overall treatment model. The National Institute of Mental Health actually is funding a lot of this research down to the molecular level, trying to understand what is it about attending 12-step meetings actually helps an individual. Now, just an example of that, we know that when a mother gives birth, there's a spike in her brain of levels of oxytocin to promote bonding. Well, studies are starting to show that individuals who are attending 12-step meetings actually have spikes in their oxytocin level, and that there's a direct correlation with attending meetings as a result of that and likelihood of maintaining abstinence over time. So those three components make up the integrated model.
So we're looking at medicine, we're looking at evidence-based psychotherapy of several kinds, and integrating an established 12-step approach. I'm going to ask Dr. Andrick, you've touched on several things that made the work that the Addiction Stabilization Unit that you worked so hard to establish important. And one of them is the symptoms of withdrawals. Somebody is brought in to an emergency room. I guess I'm going to ask you two things. If somebody's brought into an emergency room and they have overdosed, if it's a regular emergency room, what happens? What's the importance of adding services and needed medicine? And I guess I would ask you, you speak of a warm handoff, how the things that Dr. Moran describes can be made available.
Sure. What Dr. Moran was talking is really medical steps and evidence-based medicine, how to treat. What I'm going to talk is really system best practices that we should have. And in the communities like ours and many others, there are kind of two base basic approach that we should establish. One is readily available treatment, another one is warm handoff. So readily available treatment means that if I'm in a crisis, if I'm withdrawing, if I'm reaching that wow moment that sometimes addictionists talk about, I should have really red carpet to reach that help, because I might lose interest tomorrow, or I might be really depressed again to the level that I cannot even drag myself to an emergency room. So that's what we achieve at establishing an emergency room that is specialized for this. So unlike other emergency rooms, they don't know what to do with substance use disorder, because emergency room doctors are not trained in medical schools, us included, how to treat substance use disorder in emergency room setting, right? So they used to do, and many still do, like treat them and street them, right? They stabilize them after overdose, they give them a flyer in the hand, and they send them out, right? So that's not even appropriate treatment. So we need to have readily available appropriate treatment. Let's create a center of excellence. Let's create emergency room, no different than stroke center or heart center or trauma center, that in medicine, when we have complex illness that is life-threatening and very complex to treat, we tend to centralize expertise, right? Trauma surgeons, as we speak now, 2 trauma centers in this community have trauma surgeons waiting for trauma to happen and willingly accepting them. Anesthesia is trained, radiology is trained. So all that taken in consideration, that's how idea for the addiction stabilization unit was born. And then it's easier that we provide warm handoff from one centralized place than really having warm handoff in all 19 emergency rooms. So we created protocols with fire rescue, no different than trauma, again, that the fire rescue trucks bypass the closest emergency room, transfer them here where they are desired, and they know what to do with them. And then let's overwhelmingly not only have emergency room doctors trained on that, psychosocial assessment to be done by licensed professionals, nurses trained that this is not nasty Johnny. They understand chemistry of brain. They understand all those pathways that Dr. Moran was talking about. They understand that manipulation is part of their illness, that dishonesty is part of their illness, that their cortex is hijacked, their brain is not functioning, right? Those are people who leave the kids, not because they want to leave the kids. They're fighting for their lives. They are in a state that they cannot have pathways, right, straighten up very fast. So let's then overwhelming them also with offer of the peers, people who have lived experiences, who are the best to understand what they're going through, and then develop in the shortest period of time the trust and compassion that they can interpret for them what the best treatment recommendation is, so we increase chance for that warm handoff. So our peers, as we speak, literally warm hand of them, like literally holding their hands, and walk them to outpatient clinic. That's the best we can come up with. And outpatient treatment in this scenario work really the best for the most. There is statistic that we share on those task force, like, how many people had attempt of treatment before. We have over 30% of the people who report more than 10 attempts of inpatient treatment. Maybe outpatient is really best solution for that patient. Maybe we should try to rehabilitate them where they live and where they work, and try to really educate them. This is lifelong illness, as Dr. Moran said. You need your medical home for your substance use disorder forever, even when you are sober and in sustained recovery for 40 years, and then you need back surgery. Before you go to your surgery, you first have to come to us to plan your pain control, because as soon as they give you that painkiller, you will be suffering from your illness again in a full decompensated mode. So those two components were very instrumental from the beginning, that we really provide for patients and educate them that this is now your medical home. Relapse is expected in your illness, and we are here for you. Doesn't matter how bad it looks like, doesn't matter if you disappear. We are always here for you. For us, relapse needs, you just need more treatment.
Thank you. Now, in contrast, Amanda, I would say I have 2 questions. What kind of services, Dr. Moran described in depth all the different facets of treatment that are important to countering this severe disorder. And then what's important when someone's in crisis and has come close to dying as a result of an overdose. Can I ask, what was your experience when you were here. Both, what kind of services did you receive for treatment when you're in crisis? How
Yeah. Well, I'll say that after I relapsed down here and kind of went into what I would call the Florida Shuffle, what I was met with was, no treatment really at all. Like I think my therapist at one of the places actually lived in California, so I spoke to her on the phone one time while I was there in 3 weeks. We had groups that we would be bused to because at the place that we were living, it wasn't zoned for a treatment center, so we would have to have treatment happen at a different site. So we would basically just go there and sit for hours with no one to run the groups, no one trained in running groups. So no treatment really at all. I can't, speak on that because I didn't receive treatment. I received, a motel room, really. That's what my insurance card was a hotel key at that point. And that's how a lot of people treat it. And you can blame the person, saying they're abusing that system, but that's how it's set up. And
we, Dr. Andrick was saying this idea of saying you have a place to be and relapse is expected.
yeah.
What happened when you relapsed in the
Yeah.
last place?
No, promptly kicked out, not given sometimes the option to return to detox and start the miserable process all over again. At that point, that didn't seem like a good solution because I had gotten no treatment the first time around. What makes it, how is it going to work this time? And then beyond that kind of, unenthusiastic, well, you can go back here and then come right back, which is profitable to them. There was no recourse, no other solution besides the one that they were offering. So it didn't feel, that I got a lot of support when, me as a chronically relapser, and Jay included. But I also just wanted to say that within the treatment that I received down here, I can absolutely tell you that medication-assisted treatment was not one of them. It was definitely used as a detox tool, but not one that you could continue taking after treatment. In fact, you were deterred from doing that because most sober living facilities would not allow you to be there if you were on something like Suboxone. I take Suboxone, which is hard to say because there's a lot of stigma even within the treatment community and the recovery community that I'm not actually sober, but I can tell you I'm a lot better now than I was a year ago when I was trying to be sober without it. Yeah.
Thank you. Well, this brings us to talking about solutions. The opioid abatement settlement will bring funding to address addiction in Palm Beach County over the next 20 years. Al, how can the funding be best put to use?
Okay.
I'm asking you
If
first
if
because
I
you
knew
talk
the
about
answer
it.
to that, no. We are going forward. We are improving. Medical science is improving. One of the things that I can tell from Amanda's story is that she was caught in a place where there was transition, but she never knew. I'm sure you never knew about the Addiction Stabilization Unit, but we're getting the word out with people like Ariana Ciancio in Delray Beach, Jennifer Jones in Riviera Beach, where they're actually connected to the police department, and they are informing people about where they can actually get help. And that's not the private side, although I know the Addiction Stabilization Unit, all comers. Legislation. Okay, remember I said Florida is a low regulation state. The first time that best practices was ever mentioned in this context was in 2017, the first year we got legislation passed, where they actually require, meaning the law, requires when you get a license as a provider to treat in the behavioral health substance use disorder realm, that you need to use, your license needs to show best practices. So there was a place in Broward County that was getting everybody marijuana cards that came. They were using it as a marketing ploy. They've closed down. Okay, I went to the department, and we're turning things around, but I went to the department, and they said they couldn't do anything about it because they can't tell them what best practices are, which that's a cop-out, okay? We're dealing with stuff like that. But every year but one, we've passed legislation. The new legislation that's before in Florida, in Tallahassee right now, mandates you cannot discriminate against somebody if you are a certified or any recovery residence. You cannot discriminate solely on the fact that they are on medication-assisted treatment. In other words, a licensed physician is prescribing medication for their addiction. When that passes, it will be a sea change for people who are in recovery to be able to live in a sober living environment, which the opioid abatement. My thing has always been, you got 9 hours in intensive outpatient treatment that you go to a week. What are there, 168 hours in a week? Where are you for those other hours? Okay, 9 minus 168, 159. Where are you? Are you in an environment that gives you life skills, that promotes getting a job, that gives you a bond or help, assistance that is non-clinical? So I'm a big believer in no doubt, has the most certified beds in the country, in the state. And between FAR and Oxford House, there are over 10,000 sober living beds in the state of Florida. What were they, 4,000 back in 2017, perhaps? And to me, the opioid, treating the additional opioid dollars, the abatement dollars, as same old, 30 days, John Hewlick is here from the county. His big thing from the very beginning is you got to get bang for your buck because there ain't a lot of bucks. We don't have Medicaid expansion here in Florida. So what we have to use intelligently. So putting somebody in a bed for 30 days, is that really going to do it when you let them out of the bed and you say, "Hi, have a nice night," you know? You got 30 days on a two-year journey, okay? So I go and I beat my head against the wall like, maybe not Don Quixote, but Sancho Panza for sure. And I'll go to Tallahassee. I'll go, Dave Ehrenberg, by the way, gets kudos for all of this. And I do want to make mention of Alexia Cox, one of our deputy chief assistant is here in the audience. She handles domestic violence unit in county court. You talk about a tough thing to help your victims, and every single one of the people being exploited is a victim, whether it's a criminal case or not. So when you're looking at the abatement dollars, if you don't look at housing, if you don't look at sober housing and certified sober housing in the state of Florida, you're not only foolish, but you're letting down the people who need your help. We're putting new voices in the statute. Right now, the abatement council for the state is all government officials or appointees by the League of Cities, the Senate, the House, the Association of Counties, the governor, the AG, the department, all government officials. We're moving in legislation to add FAR. We're moving to add FSAM. Appoint somebody, who's an addiction, a board-certified addiction medical specialist or psychiatrist. The Surgeon General, we're asking for 2 appointments, one of which, again, we're talking about people who can inform the opioid council on, hey, these are the best practices. SAMHSA has come out with best practices for sober living. Medication-assisted treatment is a best practice. And Amanda, you are so right that most of them say, yeah, they'll take medication-assisted treatment if it's Vivitrol, which is the shot, which is an antagonist. So there's no opioid in there, like there is in buprenorphine or in methadone. You can't, this is, we're moving in the right direction. The voices need to be persistent, and we need to continue to go toward these best practices and inform the opioid council when they're sending it, and the counties, when they're getting the money, that, pay attention, don't do the same old, come up with, support some of the programs like FAR, support some of the programs like the ASU.
Thank you. Similar question to you, Dr. Moran. When we talk about having more resources, you are the one who originally told me there's very, very little medical oversight of addiction treatment, nothing to show that it's working. So I'd say there's two questions. Is there a way that you cited past anti-drug campaigns, been just saying no. Is there a way that money can be applied to ensure better science is practiced? And then also, similar question to what Al was talking about is, what is essential to a sustainable recovery? In other words, when you see a patient leave your facility, what do you want to see them have available to them?
I have so much to say about this, Antigone, you're going to have to cut me off.
Okay.
Welcome to the club, my friend. Welcome to the club.
Right? She yields her time. So Al mentioned evidence-based practice, and I did earlier, and I was so ecstatic when DCF adopted that requirement that every licensed, and they call them components, I call them levels of care, was required to utilize evidence-based practice. And then it occurred to me, now, in DCF, there are no medically trained people. How are they going to recognize evidence-based practice? So I contacted the lead counsel at DCF, Jody Abramowitz, at the time, and I shared my concern, and I said, I'll tell you what, I am willing to serve as your consultant for free, so I can teach any of your staff, any of the auditors, what evidence-based practice is. She politely declined my offer. After that was passed, I had an audit in my facility, and the auditor from DCF, who was not medically trained, she asked me the question, do you utilize evidence-based practice? I said yes. She checked the box.
Oh, man.
It's horrible. And I've said for years that I truly believe that this is one of the major factors at the root of the problem in South Florida. Because the state of Florida allows the practice of medicine without a medical license, only in the field of psychiatry. People who have no medical training whatsoever are allowed to make the most complex psychiatric diagnoses there are. People don't get well as a result of that. They're not getting the proper treatment. A patient who is presenting for treatment for addiction needs to undergo a very thorough medical evaluation, physical examination, routine blood work, a thorough psychiatric evaluation. The vast majority of individuals who suffer from opioid addiction have multiple comorbidities. That means multiple illnesses at the same time. Multiple psychiatric illnesses and medical illnesses. Now, granted, we treat what I say are the sickest of the sick, people who've been in multiple treatment programs, multiple hospitalizations, and so they tend to be complex. And I don't tend to see the mild cases, although I did when I was practicing in outpatient. But I think one of the first steps that has to be taken is to put an end to practicing medicine and psychiatry, and I have other medical colleagues here, and Dr. Andrick will tell you that psychiatry is one of the most complex specialties. And to allow people to make diagnoses and determine treatment plans, they're missing. Someone can go into a partial hospital program, be there for 2 months, leave never knowing that they have HIV, hepatitis C, hypertension, and cirrhosis. Hasn't been diagnosed. So how are you going to treat them? Of course, they wouldn't know what the treatment is. I really think it has to start there. In addition, for sustained recovery, for most people with addiction, the severe form of opioid addiction, they really need a full continuum of care. You know, I teach my students that when I was a resident, second-year resident in the early 90s, someone would come in very ill, symptomatic, having overdosed. They might be manic, psychotic, suicidal, engaging in self-injurious behavior. We kept them in the hospital on a locked psychiatric unit until we got every symptom into remission. Now, if at the end of about 4 weeks they were still symptomatic, we would transfer them to an intermediate unit, locked unit, where they would remain for an average length of stay of 4 to 6 months. If they were still ill, we would transfer them again to a long-term unit where the average length of stay was a year. We got people well back then, so they could be discharged back to the family home. Something very ugly happened in the early 90s in healthcare. Anybody know what it was? Managed care, thank you. Terrible. Practically overnight, they slashed the average length of stay to about a month, and then within a couple of years, it was 2 weeks, and most of you know that today it's 3 days. What can you do in severe psychiatric illness in 3 days? Absolutely nothing. Patients are discharged just as ill as when they went in. So to compensate for that, it's very important for that very ill person to experience stress in a gradual way. So one step down from a locked inpatient unit is the residential level of care, where there's 24-hour nursing supervision, intensive care, and medical professionals working with the patients on a daily basis, determining over time, and the length of stay being determined by one thing only, and it's not the insurance company. It's response to treatment. Is the patient clinically ready to transfer from the residential level of care to the next level, which we call the partial hospital program? That's when the patients are moved into an apartment and they begin to learn life skills, and they learn how to take responsibility for themselves. They're cleaning their apartment and washing their clothes and making their meals and planning their meals and shopping, et cetera. Things that healthy people take for granted. And they're in intensive treatment from 6 hours a day. When we think they're healthy enough, they step down to the intensive outpatient level of care, where it's only 3 hours of treatment per day. And now they're expected to take on additional responsibility and additional stress if they can tolerate it. And that's when they get a job. Menial job, so it's not too stressful for the brain. I once had an associate medical director in my facility, and he was an accomplished neurologist and addiction medicine doctor. Great guy, great doctor. And he used to share with the patients very openly that he was in recovery. And when he stepped down from the PHP level to the IOP level of care in his treatment program, a very good one in Georgia. Now, he could have gotten a job as a doctor in any emergency room, in any clinic. He was really good. Still is. He's doing research these days. His treatment team at the time said, no, 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 no. You're getting a job at Sears selling washers and dryers. And that's just what he did, and he said it was one of the most greatest, one of the best experiences he ever had in his life, because it helped him to gain a sense of humility, which in the treatment of addiction is huge. And by the way, I firmly believe that if someone does not develop that sense of humility, they'll never be well if they suffer from addiction. It's that residual pathologic narcissism that they continue to have. And then finally, stepping down from IOP to the outpatient level of care, where they should remain forever. Now, not necessarily in the treatment program where they were in the rest of the continuum, but they need to be under the care of a provider, because addiction is a chronic illness, no different from diabetes, lupus, hypertension, COPD, and it needs to be under the care of a medical provider. God willing, that individual will stay perfectly healthy and only have to drop in maybe once a year, twice a year, just to check in, make sure that if there's any evidence of regression, then more intensive treatment is provided in order to prevent a full-blown regression into relapse. That, with the support of the 12-step system, working with the sponsor in the 12-step program, which should never replace treatment, but should be part of the integrated model of treatment. That, I think, will lead to sustained recovery.
Thank you. So it sounds like the acknowledgement of the need for, just like any other illness, ongoing access to care, which I think one of the things, and we'll touch on this later, Amanda left Florida and had to figure out her insurance and start from scratch. And then the availability of enough support services to get a job and emerge slowly out of the period of needing intensive help or treatment. I do want to ask Dr. Andrick, one of the saddest things about the story that I told, what happened to Amanda's boyfriend, Jay, is he just didn't get that chance. He lost his life. He was not taken to the addiction stabilization unit on the last day when, and we were talking about this today when Amanda said, of all the times it would have made a difference, he was looking for treatment that day. But he wasn't taken there, it was 6 minutes further away. Your data, the data of what the addiction stabilization unit has shown so far is that people who do get taken there, largely walk-ins, but it makes a huge difference. They accept the offer of Suboxone, and they move on to some other care or treatment. They accept that warm handoff. However, very few people are taken there in the most, perhaps who need it the most. People who didn't walk in, they're from out of town, they were kicked out or fell out of a bad treatment center. You noted that the, having a centralized trauma system is important because then you can access the services. But what can we do, or what, again, looking at the availability of opioid abatement settlement funds, and just as a community to make sure that more people get what you've described?
Like Carl, I have idea how to spend money. So I think that substance use disorder, we repeated extensively tonight, is a mental illness, should be treated by the highest level of credentialed physicians. In order to provide that, we have to really look in other communities who already implemented this. There are clear, and talking about mental health being like any other illness, you repeated that, and especially substance use disorder is a mental health illness. How we can address mental illnesses in general in our community, because we have mental health crisis, it's not only substance use disorder crisis, it's really severe mental health crisis that we are dealing with. So we are working, I think, like, I want to kind of leave with a little bit optimism. I think that all this that we learned the last 5 years with substance use disorder and all errors that we made really led us to those moments that now community come together and really looking for best solutions. And those best solutions I'm talking about are, there are clear SAMHSA guidelines how the community as ours can really turn that ship around and implement system of care that provides this continuum that Dr. Moran is talking about. When you have a systems of care that have only highest level of care, let's say we have only Baker Act facilities. In many aspects, we have only Baker Act facilities for a lot of people who don't have insurances and things. Then we tend to overutilize only Baker Act. That's equally bad for treatment of that patient who would really do much better in partial hospitalization or assisted living facility with a nurse who's going to give the medication every day. If we put people in the highest level of care, it's really working against their better chances, right? So we have to have, if I'm suffering from mental illness, substance use disorder, I need different kind of care in different phases of my illness. And I need to have equally available, readily available, all those phases of my care. So that's what we are working right now. We are trying with managing entity and other partners in the community, all hands on deck. We are working on creating something what we call Crisis Now system of care that's going to start from the call of crisis. You are under the bridge in the middle of the night, crying alone. You are in your basement, afraid of your family member who is having first psychotic episode. We have to have that Many communities use 988 for that. It's kind of behavioral crisis line. We should not dispatch police or fire rescue. We should dispatch mobile crisis units who have licensed professionals, who have peers on those units, who know how to deal with that. We have then somewhere to take them. We are working on developing central seeing facility that will function as addiction stabilization unit. So if we implement that, then people like those young fellows who are new and who don't know where to go, it's going to be well known if you have crisis of this very low threshold, just go to central seeing facility, or if you call 911 or 988, they will be able to really take you from that moment and provide very personalized pathway how to access this care. This would be impossible without this success of this Crisis Now model will be failing if we, in the same time, don't address what we call nowadays in our team and more in all those circles with our partners, people, place, and purpose. And I know Dr. Moran talked about that social aspect, importance of job. So who are you socializing with? Where you live? What kind of job you're gonna have? You have severe mental illness. Maybe you're diagnosed with schizophrenia. That's not like end of the life. That's not like you can live normal productive life, especially if we treat you early. And especially if you don't let your brain be damaged with drugs or constantly self-medicating yourself for severe mental illness. So that's what we're gonna that's gonna be equally important from day one in this crisis of care. What kind of purpose in life you have will be equally important, like giving antipsychotic medications and it is in many communities who are implementing this. So that's what we're working right now, and we are very excited about that. There is a lot of goodwill to really finally in Palm Beach County establish something that is more sustainable for community to access all those phases of care when they need appropriately.
Thank you. So you've talked about making it easier for people to get that care, have a place to call. Alice talked about having, in law enforcement departments, community outreach workers who are bringing people, connecting people like Detective Jones to some of the resources they need. I have to ask you a minute, what is in reality right now, when you were in crisis, when you were in chaotic use and crisis, how would you characterize when you dealt with first responders, their ability to deal with what you were going through?
I think, by and large, and I was met with like a lack of sympathy, for sure. A lack of understanding is probably a better way to put it. But I do have to say there was one Riviera Beach police officer that I was Baker acted and taken in an ambulance, and he let me use his cell phone to call my mom. Like, just little acts of kindness that like humanize the addict when you feel like there's no one left in the world who sees you as a human. It makes all the difference. Like, it's so great, these policy changes, and maybe to kind of force that paradigm shift. But like, until that actually happens and we start believing these people deserve to be saved, I mean, you're going to still feel on your own as an addict, and that really gets in the way of long-term recovery, for sure. I did overdose a couple times in one day, and I was told by one of the nurses at the hospital that she was tired of bringing me back, and I'm not even criticizing her. I understand that's got to be really frustrating, to like have someone come in over and over again, and she didn't have an understanding of what I was going through. And of course it looks insane to someone who doesn't have an understanding, which is why it's so important to educate people about what it really means to have addiction. And at this point, we all either have faced it ourselves or know someone who's been affected by it, that maybe the onus shouldn't be on the addict anymore to explain it to people. Maybe we should start taking responsibility to learn about it, because it is a public health issue. It's devastating. When I first reached out to Antigone, the goal was never, an indictment of the treatment center industry or for me to be able to like talk about my experience. It was so that my boyfriend, Jay Havrilla, didn't die in a vacuum like so many other people. I just couldn't fathom that like he was going to become another statistic. And every one of those numbers represents someone like Jay who deserved having their story told. And there was still at that point the hope that maybe he would be found. And yeah, in terms of response, like from law enforcement or first responders, trying to get someone to care about a missing addict in law enforcement is hard, you know, which is why I turned to media. I needed someone to care. It felt like no one did. And I know that's not true. I know the people in this room care because they're in this room. I just want you guys to know he was a really great person, and he was more than what he died because of. And he deserved help. So many other people deserve help because the potential that they represent, like in those numbers, will never be realized. And we would be a better community if they had been. So yeah, frustrating beyond belief, the response, but a good starting point for what needs to change. Yeah.
Thank you. Yeah, I know that what you've ended up saying many times is what he would have become, who he was and what he would have become. I guess I just want to go down the line. You know, Amanda's voicing some hope, and I'll go down the line and end with you as well. Do you see the stigmas associated with addiction fading? You've been doing this for 7 years now. You've been doing it for 30. Do you see change in the mentality of the people that you talk to when you're trying to bring change? Do you think there's a greater awareness of what Amanda's talking about?
Yes, I do. Enough said, really. There's more awareness now. With fentanyl coming into the mix, many people are dying without even knowing what they're dying from. You just take a look at those West Point cadets that were in spring break in Daytona that bought cocaine, never realizing there was a lethal dose or could be potentially lethal dose of fentanyl laced in the cocaine. We're seeing a lot of polysubstance use right now, and any street drug, including Adderall, is potentially death. There was a DEA at the meeting. There was a DEA presentation. I believe it was 1 kilo of fentanyl can kill 500,000 people. Think about that. And we're in, you know, everything. It's all hands on deck, and people are realizing it because it's hitting home. You know, the numbers are staggering. And you can't find a family that doesn't have a friend, you know, relative or close or you know, or distant that has succumbed as a victim. And they're all victims. You know, the law does say if you possess fentanyl, you know, you're committing a felony. But let's face it, that's not the issue. Again, that moth is going to fly into the flame until they're no longer a moth. So yes, I've seen a sea change in people coming up and talking about their own personal experiences, vicarious experiences, or personal experiences. We have more politicians that have had close relatives or friends that have died in this epidemic. So things are changing. We're finding fewer and fewer people blaming the moth.
You know, I'm wondering, Dr. Moran, you have firsthand experience because you bring families to your facility twice a year, a few times a year, and every other month. And I think that's one of the biggest burdens I've picked up in my reporting this story is the stigma that people feel from their own families. People's families getting sick of dealing with the cycle and not understanding or not. Do you see a change? I know in your in the years of your practice and since medical school, you've definitely seen some evolution in the understanding of addiction. Are you seeing a change of the stigma lifting when people leave your facility, that they're merging into a world that maybe understands them a little better?
Yes, yes. And, you know, one of the places to see that, and I don't attend myself, but I hear my patients tell us that they're more open to sharing in their NA meetings that they do take Suboxone, and that they're not told that they're not clean, and that they should stop the medicine. So that was nice to see a few years ago starting to happen. We have a very robust family program, and we have families come in from around the country, and they come in very naive about what the disease is, but they're willing to learn. You know, I share a lecture, or provide a lecture actually to the families to educate, teaching them how to provide the emotional support that they want to provide without inadvertently helping to maintain the illness. And I actually provide a 5-hour lecture just on the disease of addiction. But I tell them at the beginning that I'm going to teach you over the course of 5 hours, and at the end of 5 hours, I'm going to ask if anyone does not believe that addiction is a brain disease. Raise your hand. And if anybody raises the hand, I'm going to continue until I do convince them. But I see a change just in the course of the weekend in terms of how they're beginning to use the language, and how they're recognizing that when their loved one is ill, they're talking to the illness. They're not talking to their loved one. And in fact, some of you are familiar with that old movie, The Exorcist, with Linda Blair. And I show a cut of that when she is bouncing up and down off the bed, and her throat is coming out and her head is twisting. And the psychiatrist comes in, called by the mother, and she just lifts her skirt. Now, she's 13 years old, and she tells the psychiatrist to F her. And of course, it ends with her getting an injection. And I say, you know, you could easily recognize that that's not the little girl driving that behavior. You all see how it's the devil. I often think that when I fall into the trap myself, when I'm talking to a patient and the patient is getting me upset, and I'm realizing, wait, I'm not talking to the patient, I'm talking to the illness. And then I completely take a different empathic approach, you know. And so I see that happening among the families as well.
And yeah, I think the biggest thing that you've moved towards, Dr. Andrick, is making it possible for people to ask for help or to accept it. Do you think there's been stigma associated with that? And do you think that when the help is accessible, the stigma lifts? In other words, people are not afraid to ask for help if they think they're actually going to get it.
I think people who come to treatment, like Dr. Moran said, we extensively train families, and all of our nurses know how to drain the chemistry and endorphins, and you know, and thanks a lot to advocates like Amanda, who turn their mess to message. I think that's very powerful because, you know, this crisis touched every single one in this room. We either have a family member or a coworker, or so it did shift in that kind of. It's not those people. It's one of us. It's us who are hit with this crisis. However, I think that we have still a lot of stigma among ourselves in medical world, and I think that's one of the most important things moving forward. Like if you have 23 years old person who come in emergency room and has 5th heart attack, and they 5 times almost died, you would have team of experts. You would be sent to Cleveland Clinic or Houston. They would do any reasonable, but you wouldn't leave that emergency room until 5 doctors come and talk to you and connect you with the services, or airlift you to higher level of care hospital because you almost died 5 times. If you have 23 years old who's coming with 5th time overdosing in emergency room, it's very normalized that, you know, so as a medical society, we still don't have the same urgency and acuity around this illness. And I think that has to shift because, and we have to provide, of course, all tools for that. But I think that's going to be addressed with this model that we are working on. We have to, all medical society in this room we have to keep ourselves accountable. So there is no, like, I talk a lot about trauma before. There is no American College of Surgeons that's going to evaluate how we provide the care and addiction stabilization unit like they do for level 1 trauma center. And there is no motivation from hospitals to do that because there is no accrediting body who's going to reimburse them more if they provide better care. So mental health, unfortunately, is a abandoned field of medicine. So it's on us that we start, but that's how it started with trauma. Enthusiasts took them 20 years to have good trauma systems. So I think we will be in different situation in 20 years, but we have to start. Medical society has to start. We all have to really have good look to ourselves in the mirror and really dedicate ourselves to implement most evidence-based practices and to apply them to everybody equally, with equal consistency. It shouldn't be random which emergency room you end up, and that determines if you live or die.
Thank you. So, and Amanda, you've talked about the stigma more eloquently than I could have even hoped, but you've dealt with something else since you've left here, is you have to make the decision about what people know about you when it's not so obvious, when you are doing well, when you look good, when you're working. And something that we had to talk about a lot is how much to identify you in this story. How much does the fear of stigma that could harm your chances to have a career, to move on with your life, how much does that affect you now?
I mean, I've always been a pretty short-sighted person, obviously, so so I think that most of it was like an inherited concern, from maybe my own family. I'm very lucky, very supportive and well-intentioned, but, in terms of like future job opportunities or, having this follow me around. Luckily, I have the benefit of like a really generic name. And also, I mean, this is so important to me. I never really wanted attention from this, but I also think that it's something that I've like silently been wanting to talk about for a long time and just never really had the platform or the reason to. I mean, I always had the reason to because I've been affected by it for a long time. I hope. Well, and the last thing I'll say is like one of my biggest concerns is talking about something and the potential reaction. I mean, I am a very sensitive person. I do, like a lot of other addicts, whether we believe it or not, care about what other people think deeply. And I don't want to come across as like, I'm not taking responsibility for my own actions. That's not what this is. It's the difference between responsibility and blame. I'm taking responsibility. I'm just asking not to be blamed for some of this stuff. And for the reasons that, the practitioners have mentioned. And I think the way to fight the stigma is that, some of us come out like in support of policies like this. I mean, I think we deserve maybe more than anyone a seat at the table too. We have the firsthand experience. We've lived through it. We've had the treatment. We know what kind of care has been effective for us, and yeah, for those reasons, I don't care. It's important to me. It would be important to Jay if he were still alive too.
Thank you. I want to open the floor for questions. Actually, I'm going to let Rick open the floor for. You look like you're going to, and you're standing near the thing there.
So what we're going to do now is we're going to open the floor, like Antigone said, to questions. Folks, we would ask if you want to ask a question, you can come up here, line up here, and all we ask is that we're going to be doing this for a little while. So all we ask is that one, you try to be succinct in your question. No speeches, please, and no politics in here.
And try to keep it singular. If you want to ask a second question, get back to the back of the line.
Right, there you go. All right, there we go. Can you give us your name, please? Is that okay?
Yes. Is this working okay?
Yes, it is.
Thanks,
sir.
working. My name is Dr. Doug Peebles. I am the Chief Medical Officer of an organization called iHelp. iHelp is an organization started by 4 pre-med students at FAU. It's called International Healthcare Enrichment and Learning Project. And the Learning Project is part of what interests me the most, is that of the roughly 60 people involved now, they're all in their 20s, they're almost all students, mostly pre-med or medical students. I got involved about a year ago when they were on the 6 o'clock news, when I saw they were having a clinic for homeless people in Boca Raton. I got involved. They asked me to be in a leadership role and made me chief medical officer. So I had to give a little context for what we're doing here. We service Camilla's House in Miami, Lotus House in Miami. We work at the St. Gregory's Church in Boca Raton. We're now moving to a clinic to Lehigh in, Lehigh it's called, in Martin County. So we're quickly expanding in a group of students that want to provide care for homeless people primarily. Obviously, we see a lot of issues with substance abuse. Talk about the Florida Shuffle. I think a lot of these people have gone through rehab, wound up back on the street, going back into rehab. So here's the problem we're having, and I sent this in an email. First of all, our growth. We're growing fairly dramatically. Interestingly, we have plenty of students that want to join our organization. We have very few physicians interested in joining the organization. So we've tried to address that, and I've sent 200 letters to physicians and spoken to untold number of physicians. Almost always the issue comes back, liability. South Florida is a very litigious state. They don't want to do something that's going to put them at risk. So I contacted the state, the Department of Health, because there's a legislation called the Access to Health Care Act, which you are probably familiar with, which provides liability for physicians who give out free medical care to homeless people and people like this sort of thing.
I just want to ask, is this leading to the question?
Is, I'm getting to the question.
Good, good.
The main problem we're having right now is recruiting physicians to continue our expansion. But when I contact the Department of Health or the county departments of health, I get crickets. I get no response. I've contacted our state legislatures. I've contacted the state senators. Nothing. We're getting no help from the state, no help from the county Department of Health. We need help so we can get a contract, as it's called, that will accommodate this Access to Health Care Act so we can recruit physicians, so we can expand, we can treat people who are homeless and have substance abuse.
Who is your question for?
How do we get help?
Okay, who's your question for?
How do we get this help?
Well, we actually have some people from the county here that you can certainly talk to. We have John Hewlick. Jim Green is over there, and he'll talk to you as well. After this forum is done, I'm sure. But that's within the county. Within the state, again, at least if this legislation passes, we'll have some board-certified of psychiatrists and board-certified addiction medicine doctors on the opioid council. So maybe there is something in that as well. But good luck. Good luck. You're a separate silo now. You got to talk to people. You got to talk to people. Come monitor a state attorney addiction recovery task force meeting, and then note the people who are there. Like Darcy Davis is here from the and Belma, and Dr. Andrick is here from the Palm Beach County Healthcare District. So, if you got a widget that seems to be working, we need widgets that are working.
Yes.
Okay.
Please see ihelpnonprofit.org.
And Dr. Peoples, I welcome your students to do rotation through my facility where they can learn all about psychiatric illness.
Hi, my name is Daniela Mauker. First of all, I want to congratulate all the speakers, especially Drs. Moran and Lily Lagrota, who helps me to introduce my daughter who is in treatment right now. I believe in this program, and my question is, I'm concerned because adolescents talk about school as distribution as drugs. So I think that in few years, we're going to see more kids in rehabs than in school. And I think that we have to attend this issue from the point start that for me, it's school. Thank you.
There's clearly not enough done in the schools regarding substance use. You know, we have an adolescent program, and the adolescents, obviously, whom we see are suffering from psychiatric illness, but they tell us that that the teachers are aware that they're using cannabis, you know, through carts during class, and just are not motivated to do anything about it.
Yes, hello. This is a very short question. And for anybody to care to answer. What is with this targeted ultrasound treatment that we saw in 60 Minutes last night?
Oh.
Did anybody see that? It's ridiculous.
Well, apparently their ratings have gone down in the last decade or two. But are you talking about...
It's an ultrasound. It's a targeted ultrasound. And this particular doctor, it was on 60 Minutes last night. It's a plaque within the brain. Sunday night.
Did they call it brain mapping?
You know, you're talking to the wrong person. It just...
No, we're talking to the right person because none of us saw the show.
Well, he stumped the panel.
Yeah.
So there we go.
Thank you to the whole panel. My name is Nicole Fehrenbach, a longtime higher ed, post-secondary educator, and a doctoral student at Johns Hopkins in education. So my passion falls right into this third part of your treatment, Dr. Moran, that you talked about. Centers need vocational and social rehabilitation as well, opportunities for that. And in the higher ed space, we are seeing an abundance of the mental health crisis, or the psychiatric illness crisis, as we want to call it, being treated, what I've come to understand, in the moment for the outcomes of the higher ed institution, which is completion, rather than in the moment education as part of a treatment plan for my lifelong psychiatric illness. The direction needs to come from the professionals like you all, so that a person who then, in recovery, starts to acquire education again, or who is in the midst of their education and starts to experience their psychiatric crisis, is receiving the education or the vocational goals from a medical professional through a treatment plan as a part of their practice. Because if we as educators are the ones treating it, even in universities that have psychiatrists, it's contingent on enrollment and towards your completion, because that's our mission, that's our vision. So until we get together and know that someone else is going to bring, but for this student, it's a 5-year plan, and it's a 1 course, and it's part of their treatment. For this vocational goal, it's 3 courses and to the job. Right, where that student, as an adult learner, is the one directing the educators in the pacing and the goals that they have towards their lifelong living with and managing their own illness. So, Dr. Moran, I'd love for you to speak to where could some of this abatement money, where could the next policy venue be beyond treatment into those spaces where the rest of us have a skill set, but we don't have the treatment plan?
That's a great point, Nicole. And I think that we're sitting in a place that could actually use some help in this regard. Our transitional living program is walking distance from here, and we've had a number of patients, when they step down to the IOP level of care, in addition to getting a part-time job, enroll in Palm Beach State College and take some courses, and then decrease the amount of work they were taking on and increase the number of courses they could handle cognitively and work toward a degree. I think it's a great idea. It has to be integrated into the overall treatment program.
Hi, I'm Lori Ginsburg. I work in the industry, and I was just wondering, this question is for you, Al. I know a lot of sober homes are FAR accredited. I mean, most of them are. I was just wondering, a lot of times people who have mental health diagnosis self-medicate on substances, and there's mental health supportive living houses, and I was just wondering if those would ever going to become FAR accredited as well too. The mental health supportive living.
I'm glad you asked the question about FAR, Florida Association of Recovery Residences, because they have a new leadership, and the last year they've made incredible strides in moving forward with their policies and procedures. Dual diagnosis houses already exist, because, well, quite frankly, if you've been listening to what's been said, especially by the doctors up here, it's almost a given that there's going to be a mental health component to substance use disorder. It's just a matter of how severe, what the diagnoses are, and catching them and being able to treat the individual for the illness that they possess. So I know we have somebody from FAR here. Shake your head, yes or no. Are you developing the idea and encouraging the idea that there need to be certified recovery residences that handle dual diagnoses? And check.
I'm not allowed to speak. I only shake my head.
Well, you know what? You know me well enough to know that whatever it is you thought I meant, I didn't mean. But perhaps, because this is a forum and all that kind of stuff, and you have knowledge, perhaps, Antigone, could you give the microphone? Mm-hmm. You've got 30 seconds, and then I'm going to go down and personally sit you down.
Speak to this. Hello, I'm Susan Ramsey, and I could go on about myself, but I won't right now. But I will say I'm a woman in long-term recovery and a grandmother, among other things. I am the general counsel for the Florida Association of Recovery Residences. It's like long. So we are specifically talking in the year coming about addressing this problem. Currently, mental health housing is not under our umbrella as it is. It's actually, I don't really know who's supposed to be managing it. I think it's the Agency for Health. It could be DCF, but these are mysteries. So one of the things that FAR wants to do is to expand this. Not only its reach in terms of, because I have a mental illness. That's what I have, a mental illness. And it's no different than the other illnesses I may currently have at my age, right? And so this is one of those chronic diseases. So yes, indeed we are. That was a long answer to a short question. But if anybody has any more questions about FAR, you can see me after we meet here.
Thank you so much.
Thank you.
I'm so glad you're here.
Me too. Should I get the mic again?
Yeah.
I've been known to.
Maybe, my question.
I'm sorry, do you need help with this? Wait, I'll help you back, yes.
Thank you.
So wait, I broke the mic. It's not a surprise, right? I do like to make a lot of noise about myself.
Thank you.
Thank you. So my name is Susan Nyamura, and I am a woman who lives with a very chronic health condition known as a mood disorder and substance use disorder. I use that term because there is a lot of stigma associated with the illness that we all struggle with. I've been in recovery for 17 years. I also sat on the board for a little while because I wanted to know how housing for people with these chronic health conditions actually work. And I always have that question because I question everything because I provide a lot of services to the community and I still see a lack of services, including that from recovery residences or respites or all of these things that are coming up because now we have new arms that are coming up under recovery residences certified by FAR that are called respites. And they're in our county, Broward County, now they're in Pasco County and the Sun Coast. And I'm wondering, because many of those individuals are being medicated and they're on medication-assisted treatment and the medication is being dispensed from these residences, and we have just talked about licensing and requirements, what is that going to look like in the future for recovery residents that are ran by operators that could potentially be like myself, a former convicted felon? And what does that look like in this shuffle?
Well, the laws have changed over the course of our task force encouraging the legislature to take care of some of the issues. To have your workforce be not be allowed to be in this space merely because they, for example, had drug convictions or maybe a theft conviction due to drugs in their past, we changed that so that there are waivers, and we actually had to work with the department for 2 years because first it was may and they wouldn't do it, so we had to say shall. Okay, so that latter part of your question as far as workforce is concerned, we addressed that with the trying to, being a convicted felon is no longer a disqualification unless it's a violent felony or a forcible felony or violence against persons. So that's number one. Number two, you can't dispense, okay? The law says you can't dispense unless you're a pharmacist or you're a qualified person to dispense. So, but there can be a lockbox where somebody observes and you can take your dosage of medication, and that includes MAT, it could be buprenorphine, or it could be some psychotropic for a different mental illness. So, you know, that's already taken care of, but a lot of people think that sober home managers, not even owners, but the managers or the certified recovery residence administrators are dispensing. They're not. Okay, does that answer your question?
Yes and no. So
the no part, one of these folks over here can answer.
So I guess I should clarify, because I know, you know, I run an RCO and I'm actually the board chair for Floridians for Recovery. So I'm all about medication.
Do you know we put you in for being
I
on?
did.
You're welcome. You're welcome.
Thank you very much. I appreciate that. So I just want to say, and it's not a jab, because I deal with recovery residences all the time, and I work with some really good recovery residences in our community, but there are still a lot of recovery residences that I would say need further education, because the same reason why they're going into recovery residences and on maintenance programs are still the same reason why they're being sent out. And some of them are functioning like res level 5s. So that's my question and my concern. I'm not saying they're all doing that, and I'm very happy with recovery residences. But my concern is when we're looking at all of this, I think we would be remiss if we're not paying a little bit closer attention, because it is a cycle, and it's a perpetual cycle that I see everywhere.
If you have concerns about, especially certified recovery residences, you should have, you should call Susan, or Josh Sasher, or now Micah Robbins, and perhaps you can discuss this after the forum. And if they're not certified, report them.
Hi, my name's Sean Leon. I'm a treatment center operator here in Palm Beach County. I've been in the treatment industry for 14 years now. I previously operated in Canada for about 10 years, where I ran a private pay treatment center where we were not told what to do by insurance companies or legislation or any laws, and we got people better. We gave them the treatment they needed for the time they needed, and we got them better. I've been in Florida since after 2017, I might add, before all the shenanigans. And my question primarily to mostly the Financial Post, with regard to your investigations and looking into the Florida Shuffle, I would say as an observer and seeing what went on here, that, and I'm not going to point fingers or say to blame, but the insurance companies fueled this. Their use and of their application of their benefits allowed this to go on, and it took them a long time to wake up. The task force had to get involved. People had to be arrested. People had to be sent to jail for them to wake up. The insurance company and the treatment primarily in the United States and in Florida was originally designed around alcohol and alcohol addiction. Fentanyl and opioid addiction is a different animal, and we're still using the same kind of guidelines and rules around alcohol to treat this opioid addiction. So my question is, where are you with the insurance companies? Have you asked them to come into this type of forum, asked them to come in and comment on what they're doing about changing their ways to be able to fund the kind of treatment that they need to fund to help these people, because they're not doing it. And
One of the
they're
first things that the task force did in 2016 and 17, we continually invited insurance companies, and they would show up to one meeting, and then they'd never show up again. They'd ghost us. Insurance companies back 7, 8 years ago were like a battleship. They were getting fleeced like nobody's business, and it took them forever to turn around. One of the reasons is that there's some side effects of the Affordable Care Act. A great piece of legislation, changed the landscape, but it had some unintended consequences. One of them was that if you're an ACA insurance company, if you're writing an insurance policy, you can't take more than 20% administrative fees. The rest has to go into the payment for the treatment. Okay, the more you charge, the more you're charged, the more you make. If you have $10 million, you make 20% of that. If you have $1 billion, you make 20% of that. So there wasn't an incentive for them to do anything. They passed on the costs to the consumers. They were at fault. They were a major problem. They still are, because they don't recognize housing, and they don't recognize the long-term continuum of care. They're starting to experiment a little bit. The last time an insurance company called me back, I believe it was Optum, and they said, we do have a pilot program like in Iowa or something, that is looking at this longer continuum, lower level of care. And as far as boots on the ground, having to deal with insurance companies, I hand the mic over to my colleague, Dr. Moran.
Thanks, Al. I heard somebody earlier talking about how mysterious it is that the insurance companies will pay for bad treatment. And, they're not recognizing it. They're not asking, did a psychiatrist actually evaluate this patient? You're telling me the patient's diagnoses. Who made those diagnoses? And then, what I end up seeing is those people who have been misdiagnosed over and over again, who have used their insurance money such that the insurance will no longer authorize treatment for me, the first opportunity for them to have real treatment. So that's a real problem, and I've been asking for years. I was talking with my billing director just the other day. I said, we see patient after patient after patient who comes from a program where there's no medical personnel. Why did the insurance company pay for that? When we are requesting authorization, they spend a long time ensuring that we're providing evidence-based care. Mystery.
Insurance companies paid for, Amanda, for your treatment when they did nothing for you. And you can bet your bottom dollar that they charge for every hour of group therapy that you didn't get. I will give you one anecdote. We prosecuted a doctor. This doctor had a reputation around town as you could go, if you're from a sober home, you go to this doctor and you could get your Xanax, so you could get whatever you wanted, okay? So we put it undercover to go there. By the way, she found out she was pregnant when she went to this doctor, but that's another story. But she went in there and said, I just want Xanax. And he said, well, wait a second. Let me ask you, do you have trouble breathing, this and that? What kind of environment you're in? Next thing you know, he's giving her all these tests for allergies. Allergies. She never complained about the allergies, okay? Now let's move on to the insurance company. It's our undercover person that's in there. This case is done, by the way. The doctor's got 5 years. Not on probation, in prison. But the upshot is we got the bill because we used phony insurance cards to go undercover. We got the bill. $18,000 was billed for this visit where all she went in, she wanted Xanax because, it makes her feel happy, right? Okay, so then we called the insurance investigator. There are precious few insurance investigators, by the way, because that's not what they do. Well, in this particular case, and I believe many cases, they don't even read the notes. This doctor every patient, 70% of the patients that went in were getting the same thing. He wasn't even changing the biographical notes. They were all white males who were 6 foot tall, including this woman that we sent in undercover, and on and on and on. I mean, it was cut and paste, the whole thing. The insurance investigator, while he's on the phone with our lead investigator of the task force, you hear him clicking. This is hearsay but it's from the source. He said, I was on the phone with this guy, and I hear his keyboard clicking, and he's going, oh my, oh my, oh my. And it was $7 million billing in, I think it was 16 months. They paid 2, right? He had a refrigerator full of compounds that he never gave to the people because they never came back. They got their Xanax and they never came back to him.
Anyway, I would just like to
So
say that
when that's happening, and that was 2017, it was not, they've cleaned up some, so that battleship is hopefully turning around a little bit, but I'll believe it when I see parity. The law says parity. Y'all know the law says parity. That's not what is happening right now. So
you guys just need to
it's
get the insurance
voices like in this room that hopefully will change that. But you're right, your insurance, God bless you, yeah.
Okay, good evening. My name is John Glover, and I am a person in long-term recovery. I'm also a certified recovery peer specialist, and I work out of Broward County, your fine neighbor to the south. And I am the assertive outreach coordinator for our RCO. And so when you talk about boots on the ground, I'm out there. I see individuals that are going through the shuffle. They're being discharged from one place and wandering the streets, and or they're aged out of their parents' insurance and they're stuck down here. And so my question is what is being done about the predatory practices from insurance companies that are sending representatives out to sober homes, to bus terminals, and places where people who are maybe underemployed or unemployed, indigent, that they are offering them free insurance that they're not able to utilize to access the services that they need to address their mental health and substance use issues.
Are you saying insurance companies are doing this, or are you saying providers are doing
No,
this?
insurance companies are doing this.
Insurance companies are signing people up at bus stations and Starbucks?
Oh, yeah. Starbucks. They're even going to recovery residents, FAR accredited recovery residences, and holding meetings with all their residents and asking.
Apparently, they know better than to do that in Palm Beach County.
Yeah.
Because we actually have a task force and we're busting people.
Yeah.
Because if they're doing it in Broward, it's the first time hearing of it.
Yeah.
And I'd like you, stick around, I want to give you a number to call to let our investigator know what's going on in Broward, just to see if it's happening in Palm Beach County, to just be aware of it. Thank you.
Yep.
I just want to warn, we're probably going to have to wind down, so we've got. How many more? Last two and concise, just so that everybody has a chance to ask. Thank you.
So my name is Matthew. I am a person in long-term recovery. I also am a C-level executive in a treatment center located in Broward. I've been in this field for the last 12 years. Mine's a kind of a two-part question, both for Al and the doctors. So the first part is, we talk about the Florida Shuffle a lot in this forum, but I haven't heard a lot of solution focus regarding how to fix that. So I'm inquiring, when the bar is set so low at DCF, where at outpatient they're allowed to have up to 50 patients to one therapist, what is the movement forward to allow that to no longer happen, to oversee these treatment centers that are accredited by DCF, but are such a low bar to give substantial care to individuals? Then my second part question is regarding the ASU and the availability to individuals. As being a person in long-term recovery and in South Florida for the last 13 years, having no idea about the ASU or programs available to individuals in recovery is disheartening on multiple levels. And then when you say that, I've read your article that you work with places in the area, how are those vetted? And then those other areas that we do give resources to indigent clients like DAF or Archways or Henderson or South County that have wait lines for days on end to get a bed, what's the fix for those individuals? So first about DCF and how we actually fix the Florida Shuffle from not really regulated well treatment centers, and then how we allow individuals to know about these resources when there are resources that have wait lists for days or months to get a bed.
Let's take the second part first. Belma, you want to handle that?
So, I mean, I cannot speak of all those agencies, but what was my agency main goal, that we provide very easy access for outpatient. And we have very low threshold. We treat everybody regardless of ability to pay, with or without insurance. Our limitation are regular hours. We open 8 to 5, and we open on weekends, but we try to really help all those treatment facilities to provide that outpatient treatment. And in the beginning, like, you know, Al said, we were all new in this, right? So we were not really trying to say outpatient is better than inpatient. We were just adding to that. But then, because we didn't have a lot of resources for beds, we become more and more brave to treat outpatiently. And so we do inductions no different than in emergency room of medication-assisted treatment. We do taper of benzos and alcohol on outpatient basis out of desperation, because we send them to inpatient detox and they discharge them like in 12 hours. So we have to do something about that, right? So I believe, and I talked a little bit earlier, I believe that outpatient treatment is really good for many people, much more than we ever thought. We have that mentality that beds and inpatient, lock them in, like separate them from outside world, because they're gonna kind of come, like, you know, finally after 10 times something will happen. I tend to believe that we have to go always in the least restrictive way so we can preserve beds for those that really needs beds, those public beds. I'm not talking about those treatment facilities, because, like, you know, usually beds are needed, to be honest, in our world. We kind of reach out to SAVBAN resources when we're dealing with somebody who's domestic violence case or somebody who's prostituting themselves, and, like, you know, they have a pimp waiting for them in a parking lot and it's toxic environment, you cannot discharge them there. But we treat homeless until once they're better, we work. If we don't, I mean, we try to really address with care coordinators where you're sleeping tonight, like, right, and try to connect them with all services. It's not always success, many times is, but outpatient treatment for us brought a lot of people to sustained recovery without beds, because we don't have beds. But again, we have to reverse that thinking, right? We have to push to have less acuity, so we reverse this, that we're investing so much money and we still have bad outcomes. So let's invest in outpatient and least restrictive crisis management, so we can really then utilize those most expensive level of cares for those that really need them.
But what's the plan to get people aware that that care is available? I worked up in Riviera Beach for 4 years at a treatment center right down the street from JFK North, and had no idea that the ASU
How long ago was that?
2017 to 2017.
Yeah, it wasn't in existence in 2017, the ASU.
It opened in 2017, correct?
So 2017 program started. ASU was open in 2019 in November, just 3 months before COVID. So, you know, it's best kept secret in many aspects. I hear you. Even here, like, right, although it's well known, like, what's his name? Jay, he passed away in 2020. Or what year he passed?
2022.
22, and he didn't know it's down the street, and he was admitted in St. Mary's.
At St. Mary's, not
So, right, there is a lot of still that traditional, like, you know, my sandbox in my sandbox. I think what I talked earlier about, this new project that we are working on, is really an attempt that we bring all community together and work together. So it's very well known where you go. If you need any mental health or substance use disorder issue, just walk in there or pick up the phone and call, and we'll take you from there.
And you're in Broward, so you need to develop, this is local. This is boots on the ground local for Palm Beach County.
I live in Boynton.
Oh, you do, so, okay. And one thing that, Belma, you didn't bring up was the fact that since 2019, the ASU concept has been expanded to JFK Central, and now we have these hubs that are available that I'm sure you're aware of because there's one in Delray Beach as well. But yeah, I mean, word of mouth, ultimately people will know. The first part of your question, we in Florida, we're the people, so the government is us, have starved the Department of Children and Families. Okay, so they don't have the medical tools that they need to make these, to determine what's the best practice. I became aware because 2017 they developed, they meaning the legislature, in law. There are 4 different classifications of fines. 2017. I asked for a public record 2 years ago, I think, a year and a half ago, said how many fines have been imposed? A simple question. How many violations have been found? About 2 months later, I got an answer back that we don't have any records fitting your request. That means 0. Now, that's the bad news. The good news is we have a very motivated secretary of the department now who came over from ACA, who has assured folks in the legislature, as well as me personally, that they are going to do better and that they are going to develop a website that actually can help people and give you information. So you can go on, you will be able to hopefully go on the department website, be able to find the good, the bad, and the ugly about the various component licenses, 3,000 of which are in Florida. So we're going forward, we're not going backwards. So the answer is, there is no answer right now, but keep tuned.
Thank you guys very much for your time.
Well, I think there's one more.
Last question.
Hi, my name is Carrie Rosser. I've owned a sober living home for 12 years. I've been a licensed therapist for almost 20. I just finished nursing school, and I'm a certified vocational rehabilitation counselor. And one thing I keep hearing everybody say, maybe it's me, that addiction is a mental health issue. Addiction is a brain disease, right? We're clear on that? Okay, good. So addiction is not a mental health issue. Just so, because I heard that said.
May I clarify that? And actually, when I hear the term mental health, I hear a chalkboard being scratched, because I'm a psychiatrist. I'm not a mental health doctor. I did a psychiatric residency. All of these 291 illnesses that we know about are psychiatric illnesses, including substance use disorders. We're maintaining stigma, we were talking about stigma before, by avoiding the use of that word. We have to use the word psychiatric instead of mental health.
It's me primarily, it's public health, but I mean brain disease. So
Okay, because I kept hearing that, and that was disturbing to me, really, because...
Yeah, I apologize.
No,
It's public health
I just
term.
think we need to stop separating. The insurance companies should have to treat it not just in parity. It should be one thing. There should be one bucket. So we should be arguing that there needs to be one bucket. There should not be a mental health manager, the people who manage the mental health. And the reason, I was told this by Ted Padich, that this became an issue is that the insurance companies did not want to do this because it was working for them. They actually, so they segued their responsibility or went around their responsibility to have to investigate fraud. So the other, so that was my biggest concern, it was that. And the other thing is, you've mentioned several times that inpatient is not as successful. Where did you get that?
I didn't say that.
Oh, I'm sorry.
I didn't say
what
that.
did you say?
I just said in desperation, when you don't have enough beds, out of desperation, we treated many patients who would be placed in a bed, then we don't have bed, we don't have any other option but treat them inpatiently. And that really kind of position us that we shift that, what we are talking about, that communities are doing. When you have more earlier care, more crisis management, then you keep beds really for those who need beds. So instead of putting everybody in a bed, what is most expensive level of care, if you provide all continuum of care, then you spend less money on the beds and you have more money to invest for the kind of upstream care.
Yeah, I own an outpatient ACA licensed mental health clinic, and what I see is, I think you mentioned it, Al, is that somebody mentioned the sandbox thing. There's a lot of this sandbox in the Southeast Florida Behavioral Health Sandbox, and I think, what is the plan to actually get all the providers together instead of the people that they know and that they know and that they're, how do you get them all? Because I made an application in 2016 for Southeast Florida Behavioral Health Network that was completely ignored because I didn't know anybody in that organization. I called repeatedly and repeatedly and repeatedly, and they lost my application, couldn't find me. So what are you doing? I also owned a methadone clinic, which I gave up, and I gave it up because of the absolute horrible, shoddy oversight of methadone clinics and how badly, how sick the people were. So so what is being done to actually get all the providers together instead of the ones that know this guy and that guy?
I cannot talk about it because I don't work with those providers. I mean, we don't oversee those providers. However, what we are working, this project I'm talking about, we are adding to all those providers. And we are inviting providers like you to join all this crisis now model in the future. So it's not that we are kind of, telling you or other providers what to do. We are building this crisis now model that we have someone to call, someone to respond, and somewhere to go, and then invite all providers to be like, after that initial crisis assessment, resource for referrals and kind of part of solution. We'll invite everybody, but if we don't have covered service line that we are talking about, we have to have absolutely all service line, including people, place, and purpose. We will come up as a community to add that service or supplement that service because we absolutely have to have all those continuum of care. I absolutely would like to be in touch with you and see how we can work together. All providers, there is no anymore us and them. There is no public and private, and right.
I'm not sure about that, but I'll
So
take your word
we
for
have
it.
new kid in the block, so let us have that enthusiasm at least for a few years until our honeymoon is over. But we really strongly believe that this crisis put us in different position, that we are more kind of less sandboxy and more kind of really camaraderie. And please join the team.
Thank you so much. It was nice. It was a wonderful forum. Thank you.
Okay. What was that? Thank you. Your combined expertise, I think, has really raised the level of the discussion. And did any of you have any final thoughts? That would be about 45 seconds each.
All I can say is, Antigone, thank you for your dogged pursuit of the truth.
Oh, geez. Thank you. Thank you very much. That was very nice.
I just want to thank Amanda coming from all the way from California to join us. I think that is advocacy.
Yeah, no, and I want to thank all of you. It's really nice to know that there are people that are willing, who have devoted their life work to this effort, and then Antigone too for, I really didn't think anyone was listening, and you were the first person to, and now I have all of these other people who I feel like are listening too, so thank you.
All right. Okay, well, I guess, let me say some final words. I'm going to stand in front of you.
That's okay.
Well, I will stand in front of you.
That's good.
I'm
going to give you rabbit ears, though.
Yeah. All right, and let me say thank you to all of you also for coming here tonight, listening and engaging. This is, as we believe, a real community issue, and one that's not going to be solved by one, two, or three of us, but the entire community caring about what happens here. To our fellow residents, our neighbors, brothers, sisters, cousins, and everything. And so we appreciate, the Palm Beach Post does, appreciate you guys coming out and talking about this. And our hope is that this goes even further, that this was just the first step in terms of talking about how we solve this problem, how we address this issue in our community. And to me, probably the most salient point that was made was that question from the last person about how are we going to work together, because we've obviously proved that we can do something, but we can't solve it with just one agency or even two. It takes all of us. So again, thank you for coming here tonight. And also, I wanted to just kind of like a pat on the back for the Post and for Antigone and Holly's work, that we have reported that there are 2 lawmakers in the Florida legislature, a high-ranking Republican in the Senate, Gail Harrell, and who is chair, I believe, of one of the health committees in the Senate, and our own Mike Caruso from Delray Beach, who have introduced legislation to actually address what was brought up in Antigone's investigation. So that is a positive step in the right direction on the state level, and we hope that they continue to move forward with this. All right. So again, thank you. Signing off, and keep reading the Post.